Hello, colleagues. It is a pleasure to have the opportunity to present at the Advanced Biotherapeutic Product Approval Education Workshop. I am Greg DeRusso, and I am the development head for hematology at Pfizer in the Global Product Development Organization. Today, I will be speaking to you about Pfizer's Hemophilia B gene therapy program. The product is fidanacogene elaparvovec, and I will first present the background for the program, including the phase 1/2 study results, and then I will discuss the phase 3 program called BeneGene, where I will discuss the program design and the top line results. Historically, there have been multiple pathways to treat the spectrum of hemophilia patients. In the 1960s through the 1990s, plasma-derived treatments were developed, followed by recombinant factors and eventually extended half-life factor replacement. In the current era, we see transformation with the development of non-factor agents and gene therapies for hemophilia. The worldwide prevalence for hemophilia A, which is factor VIII deficiency, is approximately 350,000 males. And for hemophilia B, which is factor IX deficiency, is approximately 70,000 males. For the remainder of this presentation, I will be presenting on Pfizer's Hemophilia B gene therapy, also known as fidanacogene elaparvovec. I will present a background on the program, the phase 1/2 study design, and results of the phase 1/2 study. Then I will talk about the phase 3 program, including top-line results. Please note that fidanacogene elaparvovec is an investigational gene therapy that has not been proven safe or effective. Hemophilia B is a good candidate for gene therapy. Hemophilia B is a monogenic disorder. The gene size is small, approximately 1.5 kilobase pairs for cDNA of factor IX. And this allows a straightforward packaging into an adeno-associated viral vector. There is also a wide therapeutic index, meaning a modest increase of factor IX levels to 1 to 2% can significantly modify the disease phenotype. Additionally, an activity level up to 150% appears to be very well tolerated. Factor IX is also naturally made in the liver, and specific serotypes of AAV, or adeno-associated viral vectors, have high tropism for the liver. The transgene for fidanacogene elaparvovec is a high-activity factor IX variant. This is a naturally occurring gain-of-function mutation that delivers a specific activity approximately 5 to 10 times higher relative to wild-type factor IX and results in higher activity levels per factor IX molecule. The fidanacogene elaparvovec capsule is a novel bioengineered capsid. The fidanacogene elaparvovec phase 1/2 study was designed as a dose escalation study, starting at 5 times 10 to the 11th viral genomes per kilogram. Key enrollment criteria for the phase 1/2 study are listed here and included age greater than or equal to 18, factor IX activity less than or equal to 2%, and less than 1 to 5 titer of neutralizing antibody to AAV SPARC100, also known as AAV RH74 variant. Enrollment criteria also included measures of liver health. Participants in the trial received a single infusion of fidenacogene elaparvovec and were then followed for 52 weeks, after which they were enrolled in a long-term follow-up study. As you can see on the right side of the slide, dose escalation was not progressed based on the recommendations of the Data Monitoring Committee, who recommended to expand the 5 × 10^11 viral genomes per kilogram cohort. These plots show the results of the 15 participants treated in the 5 × 10^11 viral genome per kilogram cohort. Factor activity of approximately 20% into year 4 was achieved. 15 patients have been followed with as much as 6 years of total follow-up. Mean annualized bleeding rate was less than 1, and there have been no treatment-related serious adverse events in the long-term follow-up. This schematic depicts the design of the phase 3 program called BeneGene. Participants were enrolled in a lead-in study, BeneGene-1, depicted by the green arrow on the left side of the slide, where they were followed on routine prophylaxis for a period of at least 6 months. This study, as I mentioned, was called BeneGene-1. At the end of the observation period in the lead-in study, the same participants were enrolled in the dosing study called BeneGene-2. Participants were followed for an initial 15-month period, followed by a long-term monitoring period through year 6 post-infusion. The first subject in this trial was dosed in 2019. The primary endpoint in the phase 3 BeneGene-2 study was the annualized bleeding rate for total bleeds, including bleeds that were treated and bleedings that were untreated. The comparison was fidenacogene elaparvovec week 12 through month 15 to prophylaxis in the lead-in period. A non-inferiority test was performed. Key secondary endpoints included annualized bleeding rates for treated bleeds, annualized infusion rate, and factor IX activity levels. Safety endpoints included incidence and severity of adverse events, as well as adverse events of special interest as listed in the slide. These include thrombotic events, factor IX inhibitors, hepatic malignancies, drug-related elevated hepatic transaminases, malignancy assessed as having reasonable possibility of being related to study drug. This slide shows the baseline characteristics of the 45 participants dosed. The mean age was 33 years, and all were male. There was representation from North America, Europe, Middle East, Asia Pacific, South America, and Australia. Of the 45 participants dosed, 41 completed 15 months of follow-up at the time of this data analysis. 24 completed 2 years of follow-up, and 2 completed 3 years of follow-up. This plot shows the annualized bleeding rate for the pre-infusion and post-infusion periods. Annualized bleeding rate for total bleeds decreased from a mean of 4.4 bleeds to 1.3 bleeds per year, a decrease of 71%. Treatment with fidanacogene elaparvovec significantly reduced mean treated annualized bleeding rate by 78% versus prophylaxis for a p-value of 0.001. Annualized infusion rate, or AIR, was a key secondary endpoint and was reduced by 92% compared to the pre-infusion period. 64% of the participants required no infusions of factor IX from week 12 to month 15 after infusion with fidanacogene elaparvovec. 13% of the treated patients resumed factor IX prophylaxis during the observation period. 5 resumed prophylaxis due to low factor IX activity, and 1 due to bleeding frequency. Resumption of prophylaxis occurred between 5.1 and 20.5 months after fidanacogene elaparvovec infusion. Factor IX activity levels measured using the one-stage Synthosil assay are depicted on this plot. Mean factor IX activities of 27.5% was observed at month 15 and remained stable through month 24. Regarding safety, 84% of patients experienced at least one adverse event, though none discontinued due to adverse events. Common adverse events included those related to elevated hepatic enzymes, including ALT increased and hepatic function abnormal. There were no adverse events of thrombosis, inhibitor development, or malignancy. 16% of patients experienced serious adverse events, with 1 participant experiencing treatment-related adverse events of duodenal ulcer hemorrhage and anemia. 62% of participants received at least 1 dose of corticosteroid for elevated ALT post-infusion of fidanacogene elaparvovec. The mean time to corticosteroid initiation was 45 days from the infusion, and the mean duration of corticosteroid treatment was 107 days. No participants were on corticosteroids 1 year post-infusion. In conclusion, fidenacogene elaparvovec is an adeno-associated virus-based gene therapy for hemophilia B and comprises a novel bioengineered capsid and a high-activity factor IX variant transgene. 60 participants have been treated with follow-up as long as 6 years. In the phase 3 study, fidenacogene elaparvovec yielded endogenous factor IX expression in participants with moderately severe to severe hemophilia B, resulting in significant decreases in bleeding and infusion rates, and was generally well tolerated. Treatment with fidenacogene elaparvovec met the primary endpoint and significantly reduced total annualized bleeding rate by 71% versus prophylaxis treatment, significantly reducing treated annualized bleeding rate by 78% versus prophylaxis treatment. And fidenacogene elaparvovec significantly reduced annualized infusion rate by 92% versus prophylaxis and yielded mean factor IX activity levels approximately 30% normal that were relatively stable up to 24 months post-treatment. Fidenacogene elaparvovec administered as a single infusion at a dose of 5 times 10 to the 11th viral genomes per kilogram was generally well tolerated and exhibited an acceptable safety profile. Thank you very much.